happy to introduce this next guest because there's something that I've really been thinking about when it comes to neuro injuries after birth, and an experience that I actually had treating a mom in the hospital after she actually had foot drop, and her team had waited 3 to 4 days before they actually
Oh,
referred her to physical therapy. And what I want to do is really go into that story and then connect it to why this next guest is so important. But I realized they were waiting at that time to refer her to physical therapy because they were hoping that either the epidural or whatever it was might have worn off, that she had gotten better by the time that they
mhm.
really needed to discharge her. And they didn't really want a lot of excess services, definitely on the maternity unit. And with this patient, I found that I had to, one, get a walker and use, at that time in acute care, we had ACE bandages that I
Mhm.
tied around, or really wrapped around her lower leg, connected with her foot, and helped to bring her foot up because she wasn't even able to get over to the bathroom. The nurses were not using a walker at that time. They were trying to, it's one person on either side, help her hop over to, either the bedside commode or something like that. It was just really, unfortunately, a situation where she was in bed, wasn't mobile, had just given birth. And her main goal was when she got home, she wanted to be able to walk, and not only just walk, but be able to walk and carry her baby
Her
safely.
baby,
At
yes.
that time, our hospital was tracking maternal fall rates and infant drop rates. And
Mhm.
when I think about how much time, it didn't take a lot of time at all. It was less than a half an hour that we actually were able to get her to start walking using a walker. But less than a half an hour, we were able to get mom safely ambulating with her partner. And then she was
Mhm.
discharged that day. And what I want
Mhm.
to do with Dr. Brown, you are a stroke specialist. You have been the lead therapist in the hospital that has been selected to really see and treat these patients, probably teach your colleagues about seeing maternal neurological impairments after birth, from strokes that we know occur after birth,
Mhm.
from foot drop, peripheral nerve injuries. I really have to frame it in the sense of a lot of my community are women's health therapists. A lot of us have
Yes.
treated outpatient. A lot of us don't treat in the hospital on the maternity unit. It's
Mhm.
not really common that we are even consulted. But in these cases where moms are just not walking, there's some type of injury. I remember having to advocate even in that moment with the anesthesiologist, with the OBGYN, that the sooner we address foot drop,
Yes.
the faster we
Yes.
can get people walking. And so I want
Yes.
you, if you can, introduce like your background, your experience. And just to clarify, you're not a women's health therapist, are you?
No, no, I am not. I am the neuroclinical specialist and know things, all things stroke, acquired brain injury, traumatic brain injury. And then when I got better, I just grooved into stroke. But the reason why I was asked to educate the nurses on the maternity floor, which became a ward, which became a whole building to itself at this Metro Atlanta hospital, is because I knew about foot drop from an upper motor neuron lesion, meaning a stroke in the brain, versus an epidural, where it was a lower motor neuron lesion, causing the both of which caused the foot to drop, but in different ways for different reasons. And so it started off with educating the nurses, transfers, and movement. And then it began, oh, if we're not there and the foot looks like this, I need you to do this. And yes, back in the day, I started out with ACE bandages, but based on the strength of the foot and the muscles in the anterior, lateral, and posterior compartments, I choose to use yellow TheraBand, green, or red, because when you pull the foot up, all right, you have to actively push down, and then you can slowly let it come back up. And you work these different groups eccentrically, isometrically, and concentrically. And that's what ACE bandage cannot do. And this is why the women who I saw and treated and educated, the nursing staff, the CNAs, they got better faster because I was retraining the muscles as the epidural was wearing off. Isometrically, concentrically, and eccentrically. We did it open chain and closed chain. So the mere fact from them sitting to standing from the edge of the bed, that is closed chain with the foot flat, but the TheraBand is still connected to the foot from the upper leg below the knee. And so the strengthening was occurring. And then all of a sudden, the person goes to the bathroom. Oh, that one's too stiff now. I can use something lighter. Through the education, I was able to educate the patient, all right, that as you got better the 3 days that you're here, and I'm sure they're not for normal 3 days anymore. They're probably gone the same day if there's nothing wrong. Um, they were educating other women who were walking in the halls. Oh, your foot must not be as weak as mine. I only have yellow. Why do you have red? Oh, your walking's a little bit off. Maybe you need something sturdier. And then I said, oh, we just can't fix the fit drop. I got to work on balance. I needed blankets in the room. I needed the bed locked with the rail up. We then brought in, and I asked for this. I remember asking for babies of different colors, especially when at the rehab at another facility. I wanted babies, Asian, black, and white, and I wanted the little pop up portion of the stomach so I could add weights inside for the different weights. But in acute care, they were holding on to the bed and they were practicing squatting and half kneeling and standing because these moms want to get on the floor sometimes. And then I practiced facing the bed with the rails up and then having to lower and squat so they wouldn't hurt their backs. Another thing I had to do differently for women with cesarean sections, we had to do things different. We had to breathe, hold, even the way they held the baby next to them for the compression. So when they moved, they wouldn't irritate or mess with their stitches. As long as you know your anatomy and you know kinesiology and where points of muscles are fixed versus stretch versus eccentric versus concentric, you can protect a wound. And I have had a surgery because of fibroids. So I know why the doctor didn't want me lifting anything greater than a coffee cup. And that's the same thing I needed to educate my mothers who technically want to bond with their babies, but you can't tell them not to lift their babies. So it's a whole education process. When it came to walking and I wanted to improve their balance and they were moving from the walker, and I always started off with a rolling walker, to a cane or something unilateral, then I had the babies in the wrap so their hands could be free. And the first thing we started practicing, protective responses with the hands, stepping strategies. And we stepped to 12 o'clock, 2 o'clock, 3 o'clock, both sides, because they tend to fall forward because they're in the pain of this. So you're either going to hold here or you're going to lose your step, and you got to get your hands out and you got to get your leg out in front. Some things that I avoided, why are we laying them on their back and giving them straight leg raises? Hip, ab, and abduction. I don't want to irritate the surgical site if they had a C-section. Closed chain and functional. How to roll and get out of the bed when you're laying down and you want your baby here. I need to teach you how to get up first without irritating your internal and external obliques during the move that may irritate that C-section scar, and then how to manipulate and hold your baby, how to unilateral scoot, all right, how to bilateral scoot. We are on a compliant and non-compliant surfaces, be it the hospital bed. I could let the air out or I could make it firm. I try to make everything functional for the patient. But the biggest thing, using colored TheraBands based on the weakness of the foot. The second thing, fall prevention and fall recovery whilst protecting the baby. So when you're on a rolling walker, you still want your baby with you. That's when we swaddle them and wrap them. All right. One hand with the cane. Before we transferred to one hand with the cane, we had a free hand cane and the baby swaddled here. Advanced hand holding the baby, all right, and with the cane. And then when they were confident enough, we let go of the cane, holding a pretend baby. and then the real baby with their partner nearby. And so they had to step forwards, backwards, sideways, squat, walk backwards, tandem walk, walk in a diagonal. People don't walk in a diagonal. You need to work the abductor as a frontal plane stabilizer, but then you got to kick in the tensor fascia lata and the glute minimus. We seem to forget that the med is different from the minimus, that's different from the maximus. And so I did all of those things in acute care. And I remember seeing those ladies twice a day. And it wasn't a long session, maybe 15 to 30 minutes. In evaluation, strict lower motor neurons, quick screen of the upper, all right, and then some trunk movement, all right, pain, flexion, extension, rotation of that, then a detailed lower motor neuron, including sensory, and that was it. And then I took a little picture, pasted on the bed. I don't think I had a cell phone, or they had a cell phone back then. Took it by the bed, and then the quick wrapping, and that was it. And this is how you do patient education in acute care. Can you explain to the CNA or the nurse how to wrap your foot? And when they could do that, that was the patient education, because then I knew that they knew the position of their foot. For those that were really down and in, they had to go to neutral towards eversion. So you start the wrap this way and you come up. And so those were the key things: bed mobility, transfers, gait, fall prevention, fall recovery, balance, and then educating. It was not so much I spent the time educating them, answer this. You tell me as if I was the nurse and what I need to do to best help you. It helps with autonomy, confidence, ownership of this is what's wrong with me. And I need to be able to explain it to people. And I need to say it how they can listen, because I just don't understand how women post birth are complaining to folks, I'm short of breath, I'm bleeding, this, and people aren't listening. And so I taught them how to talk with confidence. Like they knew what the issue was. Oh, you put a shot in my back at L4, L5, L3 is this, L4 is this, L5 is this. I'm having problems with these movements. It has not resolved. You can't rush me out the door. The AFO that's off the shelf, they don't have one in the hospital. It has to be ordered. Insurance will cover it. So whilst we waiting for that to be delivered here from some shop that's 18 miles away in Atlanta traffic, that's going to take 2 hours. You can come see me for a second visit, and let's get my walking together.
So, Dr. Brown, let's back up just for the people who are just right now blown away that you were
Mm-hmm,
able to do that in the hospital on the maternity unit as
mm-hmm,
a physical therapist who did not specialize in women's health and pelvic health, but you specialized in physical therapy, in neurologic physical therapy, and you were the lead at your hospital who were chosen to see these women with these specific impairments, with foot drop, with any spinal or spinal cord or neuro injury, whether it was from the epidural, if they had suffered a stroke, if they had, because of positioning or something, had foot drop. You were the therapist. And I have to just back up for a lot of the audience, because they might have missed half of what you said, and I really don't want them to, right? Just because of the
right.
terminology, and so many people just not understanding why physical therapy would be needed. And so I really just want to just hone in on that. Like, around what time was this being performed? Because I feel like we're almost going back in time, where women are being sent home not being able to walk, where women are being sent home bleeding continuously after they are already home and coming back because of hemorrhage, because of preeclampsia, all these things that we're seeing. I feel like we've diverted back and we're not using physical therapists like we used to.
So this was in the early 90s, and we had a stroke team. And so the nurses on the stroke floor knew stroke, but the nurses on the maternity ward did not. So the education started first with educating them with signs of stroke. And blood pressure is one thing, elevated, because they're monitoring that. But there are other signs of stroke that they just not may have not paid attention to: slurred speech, a little drooping of the face, Oh, I'm going to get my baby, and the arm just moves clumsy like this. Oh, and they, oh, she's just tired. She just gave birth. No, there's some true signs. So it had to start off with education. All right. And then you have to think, what's different now than it is back then? We have more people who are obese and sedentary behavior who do not regularly exercise, and they go into the pregnancy with high blood pressure, high cholesterol, and diabetes. So that's that non communicable diseases trifecta, that you're going to have the outcome of one or two things. You're either going to have a heart problem, a heart disease, heart problem, a heart attack, cardiac arrest, or you're going to have a stroke. And so now, when you have this L and D, where the family comes in for education, and now you not only have to educate the nurses, but I would be a PT when they have the classes for the husband and the wife. I would be present then to educate them on the B fast signs and what foot drop is, and these neurological conditions for an upper motor neuron, things from the brain, versus a lower motor neuron from the things from the spine on down. So that's what we weren't doing. But what we were really doing well was educating the nurses. So when the nurses started seeing this sign, immediately you get a referral for the neurologist and the stroke team. It just said stroke team, and that automatically meant OT, PT, and speech. And then we come in, do our evaluations, we round it. Sometimes it was just a light motor stroke, and they really needed gait training and then AFO. And at this point where I was at this facility, we weren't making them. But when I transferred to another facility and I really honed in on my skills, in 45 minutes, I could whip up an AFO. And those women that we treated there at that facility had already given birth. Baby was home, but now they're going to outpatient rehab if they're not on an inpatient. And let me, at one facility, I was in the day rehab program and outpatient. I requested the little playpen that's like the 4 feet playpen with the net. I requested that, and I requested a stroller, because they got to push a baby and they're not going to push it on a rolling walker. Let's be real. How do we make the stroller so that the wheels turn 360 degrees? It has a lever brake up on the arm, and it's situated where the mother can squat and rotate and get the baby and feel safe and confident. And so, again, it was education, starting off with the nurses. And then, if I had to do it all over again in present time, I would be present in those classes where the parents come and learn about birth and everything. They need to be learning about therapy. All right. Because it's the physical therapist that's going to help do the proper exercises for the core to help with the healing if they have a C-section, or if they have a rupture in the split down in that pelvic area, which is painful, that leads to antalgic gait. That separation of the pubis symphysis leads to antalgic gait. Just that separation disorients the muscles, the Poogie Q muscles, your hip stabilizer, your hip abductor. So just the nuances of the education about that. And so that's why I see the real difference, because people are coming in with a different health status.
And also, the information that they were being given through the nursing team is different as well. Do you
Yes.
feel like there was just this drop off just in the field? I mean, I'd never heard of anything like this, and I have been searching. Dr. Brown, just to give you some background,
Uh-huh.
because of the work that I do, I have been searching really through just practice at this time, because it's not written in history books what you did. It
No,
is
it's
not
not.
written in
It's not.
history books what
No,
you did, and I'm trying to not just I'm going beyond women's health therapy at this point, because I
you are.
knew that we were not seeing that patient population really as a standard of practice,
Mm-mm.
and I knew that acute care therapists were in their career, and several therapists have reached out to me, but this is the first time I've actually been able to get someone on this podcast to just talk about what their practice was so I can start to connect the dots and almost bridge that gap from what you were doing to what is being done now. And so I understand completely the health status of our maternal population has changed. But then also, even for the healthy moms, I have treated moms who were healthy and who presented with those impairments because of maybe positioning or some type of injury, an unplanned C-section, if you will,
Mm-hmm.
preeclampsia,
Mm-hmm.
all those things that really can't be explained by obesity, by diabetes, which they didn't have, and yet still the information that they're given is in my opinion, is just way too late. You're talking about early acute
Yes.
interventions.
Yes. Okay. So here's the thing. At the very first hospital in the early 90s, I must admit I had an advocate, and she was a neurologist. And me and my occupational teammate, we did the map for the hospital system, not just the hospital system. And we presented at this at a CSM when it was in Atlanta. So whether you had an ischemic or hemorrhagic stroke, where do you go and how was the origin of that? Because we would have people on 285 who had a stroke and caused the accident, and you think it was an MVA due to TBI. No, the person was having a stroke. All right, that was first. And they find that on imaging, and then everything came afterwards. So with these moms, the nurses were educated and they knew to call. And then when the call came down, if I'm working, I was the person to go. I was the person interested. So now, for those people who may just have a positioning problem, an emergency section, um, you need an advocate. And once the advocate says it's on the list of things, because it really, we had a protocol. It was a protocol. If it's this, they're going to be here 3 days, they go here. If it's one day, pure motor stroke, they can do the outcomes test. We did the high level test. Then they can be discharged home. They're going to come to our outpatient, blah, blah, blah. And so those how things are in place. But on your list of your protocol, physical therapy consult. And you need to have an advocate for that to put you on the list. So if there is an emergency section and she cannot hold and walk and she requires a rolling walker, then she needs to be educated on that before discharge. But you need an advocate, and then the advocate presents to the team and they bring your value to the team. And then all of a sudden, when you have these blanket orders lists, you have the blanket physical therapy order or the blanket OT order. And guess what? We as doctors of physical therapy, and us old school with the entry level master's degree, um, I should know, based on subjective history, pathophysiology of the medical diagnosis, if my services are needed or not. So don't wait after the fact to add me. Put me on from the get go and let me come in and do the judgment call based on my expertise. So I think that's the key difference. There was an advocate. She was a neurologist. And when we started seeing these problems from the maternal ward, I said, well, we got to include them in the mix. And so everybody didn't want to get trained, and because we had a stroke team per se, but a little foot drop. And guess what? One of the moms, and you're right, the epidural does wear off and go away. I trained her and trained her well. Do you know when she came back for her well baby check, she brought the AFO back and said, well, somebody else can use this because I can do the things that you told me to do. She had to jump. She had to jump. And then I said, if you're really good, you got to jump rope. And then you got to skip. You got to do 1 foot. And when you can do that and land down and your ankle isn't all wibbly wobbly and you can walk across your room holding your baby on your toes and on your heels, then you don't have to wear the AFO anymore.
You would
And
have them do a jump test to
yeah,
determine. Yeah.
if they don't need the AFO anymore. Because the anterior and lateral and posterior compartment has to work. They got the push off and they need to land easy, eccentrically. Oh, yeah. And here's another thing. And I tell people this all the time. If you want your mother to be able to get down to the floor and squat and pick up baby, and I do the developmental sequence with my mothers. Okay, you got to give them an AFO that has Velcro with tension that will stretch so that the tibia can come forward. All righty. We
So
lock their,
elastic.
yes, these are different tensions, Velcro. And it depends on how weak the muscle was. I had a whole different type. So if the muscle was a 3, it's going to get an easy one. But if it was a 1+ and big, it's got to get a rigid one. This one's really rigid. I'm really pulling on it. But no one got the standard AFO. And all of my AFOs, my samples that I have in the house here, none of them have the original Velcro that goes through the metal loop. None of them. Because if you're restricting the tibia, you're preventing the potential of isometric, concentric, and eccentric muscle activity for the anterior, lateral, and posterior compartments of the leg. So it's
Explain that
more.
just for someone who doesn't understand, because some of our listeners, and I wanna just kind of include them, they're
Mhm.
doulas, and sometimes
Yes.
they're really present to see that these complications. They may go the long route, talk to the nurse, talk to the doctor might say, "It'll wear off, it'll get better," and while they're taking the scenic route to recovery, we could have been consulted, and we
Yes.
see it all the time, Dr. Brown. So for
Yes.
someone who's not understanding the eccentric, the concentric, or the Velcro
Sure.
tension, all of that, what do you mean that no you the moms that you saw didn't go home with the original strap? Are you saying that you changed the strap? You
I
changed the
most certainly
structure?
did. I most certainly did because I did fall recovery and fall prevention. So if I'm going to put them in an AFO, this is the AFO where their leg is stuck here and it cannot move, it's rigid, it cannot move. If I want the leg to come forward slowly, the calf muscle is working eccentrically. But if I'm in a squat position and I stand up, that calf muscle pulls the leg back. That's concentric, it's shortening. If my foot is down and I have to pull it up, the muscle's shortening. That's concentric. If I have it up in the air and you hear this slap every time your mom's
Mhm.
walking, that means that the muscle in the front of the leg has poor eccentric or lengthening control. It's just hitting the ground. It's slapping.
Mhm.
Every time that slap, that's a fall problem.
It really was, and the patient that I even brought up at the beginning, she was scuffing her toe, essentially.
Yeah.
Scuffing her toe, like, she could
Right.
not clear her toe until I did the thing with the ace bandage, didn't even
Yes.
think about TheraBand. Never
No.
even thought about how, you did, those photos that you sent. First of all, that PDF is
Mhm.
going out everywhere.
Okay.
That is absolute every single person is going to have a link to just get that PDF. It's absolute gold. I had
Thank
never
you.
seen anything like that, especially in the
Thank
in
you.
the context of who we're talking about. You've
Thank you.
used your expertise to provide services for this population at a time where we're looking back now and we're thinking, how do we even do that? How do we get even the current therapists trained to do those
Yeah.
interventions so that in the event we don't have an outpatient facility that has a wait time that's pretty reasonable for someone to be seen within the first week
Mhm.
or two, maybe moms can be sent home with something
Yes.
until they're able to see that therapist on the, outpatient side. But right now, they are getting discharged probably so much earlier than maybe even
Yes, they
you
are.
saw. And
Yes.
and and what's the likelihood that they're gonna even encounter a therapist who's gonna do all of those things in that full assessment?
So let's take it a step further. So you have an advocate on that list to do physical therapy consult. And in the take home packet, you have foot drop. And in my book, like in, I don't know, chapter 1 or chapter 2, I explain foot drop from an upper motor neuron lesion to a lower motor neuron lesion, what it would look like, floppy foot, low tone. One clear page in the take home packet for that mom could be added, and you could just show how to start the taping mechanism, the TheraBand mechanism, and 4 feet of TheraBand. That's it. You get the color, and I really think I've gotten really good at this color tension thing based on the weakness, because when I was at Ohio University working with some engineers, because we were going to start scanning the foot for an AFO, and we were creating an algorithm of how thick or thin the plastic of the AFO had to be based on how strong or weak the muscles were and the tone. It's the same principle for making the mock AFO out of the TheraBand. And every woman doesn't want their leg wrapped up on the outside. So I tell them, get yourself some $2 pants that got the wide bell bottom legs, put on your sneakers, and we're just going to take the front of the TheraBand, and where your laces are, we can do one loop through the lace, bring it up, and we can pull a little bit more to the outside of the leg and wrap it around at the top of the calf, or just pull it neutral, because a lot of them go down and in. And so we can just pull it up. But something simple, one page that goes into the packet. So now that's how you help the women who probably won't get in to see PT, because guess what? The first 2 or 3 weeks, they got to go to baby checks and do all of that. Things get straight, and they may not have time for PT. But
Absolutely, and
if,
some of these moms are in the NICU. We have such an
right,
increase of preterm deliveries in the
okay,
United States. We have more babies being born prematurely, and so
okay,
moms are still recovering from their own
right.
injuries, and then they're in chairs that were not designed for their recovery in the NICU
Exactly.
for hours at a time.
Exactly. Okay, so here's the thing. And this is why we as physical therapists are movement specialists, but we may want to start looking at some other things that make us do our jobs even better. Those top three non communicable diseases that I mentioned earlier, high blood pressure, cholesterol, and diabetes, the food we eat is what's causing, I think, these new preemie babies. That's causing the preeclampsia and the issues that you see during the pregnancy, and then everything just spikes. It just seems like it spikes. The blood sugar spikes, the blood pressure strikes, and that makes it right to have an upper motor neuron lesion, a neurological event like a stroke. And they're eating their comfort food, but eating the comfort food has all the things that's not nutritious to the cell at the cellular level. And I think we don't link nutrition with impairment with functional outcome.
So are you saying that we to work even further upstream, because as far as upstream as I've gone as a women's health physical therapist has been the hospital. But you're
Hmm.
saying even during pregnancy, we should really be guiding moms to getting a dietitian or a nutrition registered dietitian
Yes,
consult. Every
yes,
mom gets a
yes,
registered dietitian consult during pregnancy, regardless of their
yes,
health status.
yes, yes. Because your
What
diabetes can be managed, but things spike during the pregnancy period the closer it's time for the child to be born. And I think about people that I know that had a quote unquote rough pregnancy. I'm telling you, maybe I should have been the one to bring the salad to the dinner party as opposed to what they wanted. Something in addition, and then the healthy version of what they wanted.
for those moms, I have to ask you this, that may have had an issue, right? Whether it was diet related, whether it was lifestyle related or anything. What was one of the most common causes for the issues that you treated, that your team treated in the hospital after birth? The neurologic injuries, what were the common causes then compared to what they are now?
Okay. Then I think people were just in a rush and they were waiting at the last minute and they had to get the epidural, and they're in so much pain, they're squirming. Now, women are built different, and they're built different for reasons. Sedentary, working at the job, bringing home the bacon, don't exercise regularly, and We carry more weight because of the food density that we eat. The food is dense, but it's not nutritionally dense. And so we gain more weight during pregnancy that we don't need, that the baby doesn't need. But that's because of the nutrition of the food. So that's what I think a bigger issue is between then. They were just late, came in last minute, but now you got some issues. You're walking a little slower, you're carrying more weight. So that's not necessarily that they're late. It's just their body in context of what they have to do. And guess what? When they have the stroke from the upper motor neuron lesion, they feel that they are just so much heavier and so much weak. When in essence, the leg that's weak weighs the same amount as the other leg that's weak. The arm that's weak weighs the same amount as the other arm. So when you're carrying more weight than necessary and you have a stroke, it's a whole lot more work because now you got to lose weight and you got to exercise and you got to exercise at a higher intensity to release the BDNF factors and all these things we need for neuroplasticity. All right. And so you're doing double the work. So I think it's two things. I really do think the women are doing what they have to do to survive. They got to go to work and they're leading sedentary jobs and they don't have time to exercise and care for themselves. Their babies need nutrition through this 9-month course, but the food we are eating is food dense, but not food rich in nutrition at the cellular level. And food dense gets stored as fat.
What I have these conversations, Dr. Brown, and this is just so interesting to me because I'm seeing it as well. I'm seeing more moms during pregnancy, and the conversations are hard. It is just like
Mhm.
what you're saying. They're working longer hours,
Yep.
right? Just in terms of just their job. Uh, they are, especially with the populations that I'm seeing, even virtual through telehealth,
Mhm.
they are choosing those appointments because it really just fits with their lifestyle. They don't have the
Oh,
time to
right.
break, go to an appointment, see someone, and then they're not using a standing desk. So they're sitting during the day.
Mhm.
And these are moms that are preparing for pregnancy that are reminding me of the moms that I saw in the high risk pregnancy unit that
Yeah.
were just not moving. And I'm like, this is kind of the same situation. You can move. It would be healthy for you to move, but it's just not being incorporated into your day. You're sitting for hours on end, very similar to those moms who would be sitting in the hospital, during their high risk pregnancy admission. And I have to really kind of change my mindset that I am preparing them for a marathon event, which is
You
birth.
are.
But
You
then
are.
when they do sustain an injury, we had all of that in terms of a ramp up period, which wasn't
Yeah.
really a ramp up period as well, physically. So there's muscle atrophy.
Yep.
There's a lot more
Mhm.
just endurance issues. I'm seeing that even
Yes.
with the use of the incentive spirometer after C-section, not only does it, not feel good to take a big breath in, but they're not getting as much on the incentive spirometer. So I'm seeing all of this
Exactly.
effect when I'm treating patients really early after recovery. And so you're bringing more of a wealth of information of how more upstream we really need to be as
Mhm.
physical therapists. We really need to be in these wellness spaces. Is that right?
You are absolutely right. And I didn't put it in this PowerPoint, so I'm apologizing now. It may be in another PowerPoint. And if everybody wants this information, go to LinkedIn and look up Mike Studer, Dr. Mike Studer. He has put together a nice piece on vigorous lifestyle intensity physical activity. And I forgot the man because I just referenced him. There are two articles that I use from where Mike gathered this information from. And if the women could do an exercise snack, that's all it takes, an exercise snack. So for every hour or every 30 minutes that you're on your computer, you need to stop and take an exercise snack.
Okay,
And
Dr. Brown, I have to stop you there before you just go. I have to say that I might have stolen something from you because ever since that we met, really at the Education and Leadership Conference, I've
uh-huh.
you are just coming up on my feed, so you will not believe this, but I actually am prescribing movement snacks And you just said exercise snacks. And I'm like,
Right.
okay, I got that term from somebody and now I know who I got it from.
So again, I have to give my friend Dr. Mike Studer, a neuroclinical physical therapist. He has camo, and when I had my sickle cell that sent me to the hospital, I was weak as water. I couldn't move. I couldn't do anything, and I followed the principles of camo. Any movement is good movement. So I'm just thinking for the woman who's in the chair and she's going to be on stirrups like this. So why can't she hold on to her desk with her hands and do 30 seconds of this, of lift ups? That's all she has to do. And if you can do intense, short bouts of exercise, it would be easy. Even if she got up from her desk where she's sitting and be in this squat position and heel toes up, just 30 seconds of intense movement. Anything will help. That's the upstream thing during the pregnancy. I know women who run during their pregnancies and they're safe, but these women have been active all their lives. We need to hone in on the ones who are not relatively active, because at that point for birth, that's when things get really just tedious, especially for the upper motor neuron lesions when they have the trifecta. I call it the trifecta now: cholesterol, diabetes, and hypertension. So if I can get them with these, what you call movement snacks, exercise snacks, and there's literature to support this, high intensity, short bouts, any movement is good, but I need it to be done early on. And guess what? That high intensity exercise, I bet you'll see a difference in your center spirometry.
How early on?
I would say during the whole
First trimester?
pregnancy.
First
Yes,
trimester,
let's start.
okay.
Let's start, especially if you have to work. Women are working up to the day of birth. So if you're working, I need you to take time. If you can't go to the gym for an hour, you don't have 30 minutes set aside in your house. Every time you get up to go to the bathroom, we need to do some high intensity movement of some sort, an exercise snack, and start building that. That should be the normative model. I know as they get larger in the position of the baby, they can't really walk and rotate and things change. But put a little briskness in your step. It's going to help with that birth process. It's going to help to dilate your arteries. So you won't have the chance of having an aneurysm or an ischemic event. That's what you don't want. So you have to prepare, like you said, upstream. I know, just to review, we've talked about a couple things. You need to have physical therapy as a standing order. You need to have an advocate. In that take home packet from the L&D for anyone who got a physical therapy service, one page education packet during the time when the husband and the wife and whoever comes in for that 8 weeks, PT needs to be present. Didn't we do back education for everybody who was coming in to work at the hospital through human resources? Why not be included in that? And then we need to let midwives and doulas know when the physician is not seeing them, upstream exercise. What's your exercise activity been like this trimester? How many are you getting? What the recommendations from CDC? That 150 minutes of moderate to vigorous exercise. And if you're not, why not? How is it that I can help recommend something for you to do?
Dr. Brown, why weren't you my professor? I no, I want to just ask. No, really, no, seriously. Why were you not my professor? And I have to say this. First of all, I think that we sometimes box our specialists, to our
Mhm,
detriment. But I
mhm,
have to say, when I was a PT student, I was particularly interested in neuro because about 3 months before I started PT school, my mother had a massive stroke, never
mhm.
recovered. 3 months right before I started PT school, struggled all throughout PT school. And thankfully I made it to the second year. I made it, obviously I graduated, but
Yes, you did.
yeah, that first year was so hard. But when I made it to the second year and they started the neuro content, I was all in those were the hardest classes.
Yeah.
Neurophysical therapy were the hardest classes. But what got my attention was not in cardiopulmonary, was not in musculoskeletal, was the preventative nature that the neuro professors that we had taught their classes. They taught with the mindset of, I will teach you as a student to graduate and be able to treat someone who's had a stroke, but I'd rather you learn how to prevent one. I'd rather you learn how to prevent a lot of these chronic impairments that people have who suffered a stroke, who suffered a nerve or spinal cord injury or something like that, a brain injury, whatever it was. And it was my neuro professors who felt they taught me the boxing for
Yeah.
Parkinson's
Hmm.
disease for that patient population. They taught all these high intense training, how to monitor those vital signs so that you're not tipping that person over the edge. But it was the
Yeah.
neuro professors that I had that made me understand this is preventative care. This is what I came
Yeah.
for. This is why
Yeah.
I'm going to graduate and get through this program because I wanted to prevent these issues. So where were you? Where were you when I was going through school and just knowing I wanted to do this, but now here was this whole population that was underserved? I had never heard of PT being on the maternity unit.
Yes. Again, I think everybody's talking about AI and data analytics. When I was doing neuro at that first hospital, I started just collecting data. We just take the patient, this name, wipe out the name and identifying characteristics and put the lesion. And we had the age. And we're getting this from this, and this. And then, we have some of these outliers. Okay, this is when some of the outliers stop. When there was a helmet law passed, things dipped down. You know, um, when there was a big change in insurance and Medicare went through some changes, all of a sudden things kind of spiked. And I wonder if that's because people weren't going for their preventative checkups to check their blood pressure. And back in the day, cholesterol was the problem. It wasn't diabetes. Now the problem is sugar and diabetes. That's more so the problem that's causing our blood coagulation problems. That's causing all of these multiple problems with stroke and heart disease, I would say. But where was I? I was so busy being a good clinician. And then, Dr. Linda Woodruff, bless her soul, she says, "Girl, you need to be in the classroom." I was like, I don't know. I went to go back to get that PhD late. And I must say, looking back on it now, I struggled in the classroom. And I think the reason why I struggled because the energy that I bring now to this podcast with the bar up here and having the strength to link neuroanatomy with stroke or acquired brain injury impairment and understand functional outcome in the context of the person, social determinants of health, that's my gift. And even though I have a PhD and all this kind of stuff in educational pedagogy, that's not my strength. And and it took me a while to come to that, and maybe I was trying to please and appease Dr. Linda Woodruff because she said people like us needed to be in the classroom. I'm really good at continuing education and doing this type of teaching. That's my gift. And I wouldn't have gone back to be a professor if it wasn't for Dr. Linda Woodruff. And so I took a road less traveled. I've been board certified for 4 10-year terms. It's been worth it. But I think now, what I'm doing now as a 59-year-old is the best teaching I've ever done.
You wrote a book that I feel like is applicable for all of us.
Uh-huh.
You really did. I mean, Brace Yourself is applicable for all of us. I wish I had that education, not just in the women's health realm. I've practiced across different settings, but I'm like, how many people could have just benefited from this earlier intervention, right? And then maybe wean
Yes.
off of it, right? But at least have
Yes.
it and understand the
Yes.
differences, right?
Right. And to this day, I don't think people understand why some of my clients wean out of an AFO and some do not. The first thing is that they get great emergent care. So they reduce the stroke infarct, the black area, and the penumbra is large. The longer you wait, the larger that stroke infarct area gets, and it's black. Those neurons are dead. They are not coming back. So that's the first thing. The second thing I think is I understand stroke or acquired brain injury impairment, the lesion location, what that area is responsible for, and the potential for functional outcome. The third thing is I look at um, recovery in terms at the body structure function level and the activity level, and then I take it to the participation level. So that old ICF model, I'm an old school trained girl. I'm not this CPG, these clinical something guidelines. Well, they had this, let's just follow this guideline. No, I'm one of these social determinants of health, old school people. And I really do think that's why my folks get better, because I know the lesion severity and how large it is. I don't have privy to an MRI and all those things all the time, or diffusion tensor imaging that just shows you it's damaged or not. But I know how to do a full examination of all systems, not just the neuro system, but musculoskeletal, cardiopulmonary, integumentary. I examine all the systems, and I evaluate the data from all the systems to get the best plan of care within the scope or the lens of the patient or the family or the caregivers. And that's why they get the best AFO for them, and they can wean out of it. I meet a lot of people who've had a stroke. Just did a consult on Monday. Well, we're expecting you to come in here and get him up and get him walking. And I said, well, let's just wait a minute. Hold on. And then you have to do an anatomy lesson with them and
Mm.
actually show them where everything is and draw the pictures out. And I'm thinking, who takes the time anymore to do this with patients? And so once you take that extra step, and you understand impairment and outcome at the body structure function level, activity level, and then you have to wean into the participation level, you won't be sending your patient home with 18 pages of exercises when they ain't never exercised a day in their life. I
Do you
have
think
patients like that.
I think and I'm guilty of this too, is that I will tell therapists who just say, Rebecca, we don't have time to, we have 13 or more patients or whatever it is on our list as an acute care therapist. We don't have time. Can we just get a packet of information? And that person's just going to treat that packet of information. We know that. Like the rest of the packet of information is going to stay in the folder, most likely, and they're not going to be taught or educated in terms of their home environment. Going up and down stairs might do this. After C-section, you might feel this. Standing in the shower, that's going to tax your body and your energy like this.
Mm-hmm.
If we even took just a few minutes more to just explain that, we'd probably throw our exercise packet out the window and just really fit the interventions that that person needs in that moment,
So
or
then why
direct them.
So here's the decision you have to make. You have to prioritize. Am I going to give an intervention at the activity level or at the body structure function level? Maybe just one thing for the foot, for foot drop at the body structure function level. Let's focus on eccentric tibialis anterior, the leg in the front of the leg, the muscle in front of the leg to pull the foot up. Let's just focus on eccentric. All the other exercises, sit to stand, feet together, toes turned out, heels turned out, and wide squat, sit to stand. That's it. Those are all the exercises done. That's it. Once I've gotten all those in, I've done everything. And then they know to walk because we've educated them on walking on day one. That's it. So I think less is more.
Less is more.
Focus is better. Less is more in focus. During sit to stand, if you can accomplish standing up holding your baby, then you can squat down to the floor
Mm. So,
because
Dr.
you lower the level of the surface from which you have to stand. That's all you have
From
to
which
do.
you have to stand.
Yeah, you lower the level. That's all you have to do. That's all you have to do.
Dr. Brand, you gave me more than I think I even expected, really, from our conversation. I just want to recap for therapists, really, who are treating this patient population, right?
Hmm.
Neurotrained therapists, for
Yeah.
example, who might not even think, oh man, well, yes, I was consulted. This patient couldn't walk. It might have been a peripheral injury, a nerve injury from the way that they were positioned during labor and delivery. It
Hmm.
might have been from the epidural. Maybe these are signs and symptoms of a stroke. Maybe these are different patient populations. But for just that therapist, occupational therapist, or physical therapist, I
Hmm.
think this conversation alone has probably just expanded a lot of the tools, right, in their toolkit. That just from this
Yes.
conversation alone. Where I want to land really is just in general. I think that the premise that you started with in your practice and that you still really exemplify today is the ability to communicate your value, your not just who you are, your clinical value is just really beyond. I think everyone can agree, even the clinical specialist level. I think it's just beyond because of the expertise and the way that you've been able to pull. You're not in a silo. You're able to
Right.
treat patient populations across several different diagnoses. But
Hmm.
what we, I think, probably could use a workshop on is communicating our value across disciplines, having advocates in other areas of practice, whether it's in OBGYN, whether it's in neurology, be able to say, we need physical therapy on our team. We're not seeing that on the maternal care team. We're seeing it on after cardiac surgery. We're seeing it in neurology for sure. We've had many advocates after musculoskeletal injuries, but
Hmm.
where all these things intersect after birth, we don't have the advocates. What do we need to do as professionals to really raise up our advocates in this particular area?
So, for anyone in acute care that has a maternal hospital, a ward, a floor, start collecting the data every time you get an order for a woman postpartum, be it for stroke, from an upper motor neuron lesion or a lower motor neuron lesion. Start collecting the data, diagnosis, when the PT consult came, because that's the answer right there. When it came, how long it took you to fulfill answering that consult, and then how long they were in the hospital. Because you want to be consulted earlier, you want to reduce the length of stay in the hospital and make sure that person gets to the right place downstream in the health continuum of care. All right. And because you want to reduce their length of stay to get them out. So I would start collecting the data. Now, when you collect the data, you look at your notes. Now, really look at their notes. What outcome measures did we use? What intervention addressed the deficit in the outcome measure shown? And then before discharge, which we fail to do. If you know someone's going home, do a repeat of those outcome measures to show the effectiveness of your treatment. That's where the value comes in. We aren't collecting the data and we aren't giving the data. I wrote a paper on this and it got published with Dr. Julie Sher out of Ohio, a team effort. She's in psychology, she does neuropsychology and behavior. And she has been mentoring me, and we've been writing papers together. And all we asked in a survey, are you collecting data on foot drop with outcome measures? What are you doing with the data? Are you sending it to the insurance company? It was a very good paper, it turned out to be. We got, just different information. But I'm driven by data now. And guess what? Evidence based practice, practice based and evidence based. A lot of people work in the clinic, in this clinical environment, and they don't have time to be writing these papers with interventions and taking away and they don't double-sided blindness. What you do is worth hearing. Write it up. It can get published somewhere, somehow. You have the evidence. So collect the data and start writing what you do. Once a quarter, 2 hours, all the clinicians gonna get together. This is our data. Let's write a paper. If you're not good at writing, but you can collect the data, you hire someone like a Jennifaye to write the paper. That's retired folks full time. That's gotten more papers published since
Is
we've
that
been
really
in
a
it.
thing? No,
Oh gosh.
I do wonder, is that really can therapists, and I just wanna, like, this is an aside, but really even for
Uh-huh.
me, I feel like I'm paying for a consultation, but I'm not, 'cause 'cause, I mean, I appreciate you, like, dropping all of these gems, but I think where I struggle is we've gone after the grants, we've gone after this, we've gone after that, and I'm just like, "Man, if I could just get the data from a hospital, that I don't work at,
Mhm.
could I have help writing this up?" And I'm like,
Yes.
do people can you hire people to write up your data for you?
So this is where you start. For every DPT program that's affiliated with a university hospital system, they all need to do a, what do you call that thing when you graduate, some kind of practice, some kind of
Capstone.
practical, a capstone. There you go. You will be on it. The student's name will be on it. The student's advisor's name will be on it. And if you're affiliated with a hospital university system, easy peasy, easy peasy. And guess what? We just have to make the time. I haven't worked full time since July 31st, 2024. I still meet with a group of ladies from 2 to 4 or 3 to 5 every Tuesday. The only reason why I wasn't there yesterday because I had to teach CPR every Tuesday
Amazing.
on my schedule.
Amazing. Dr. Brown, is there anything else that you want just therapists to know who are in this field, who might be entry level? We have a lot of entry level therapists that are coming out of school. They want to apply what they learned. They're some of the smartest in our profession, right? They want to apply everything that they learned in every single course in PT school, and they want to apply it. A lot of them are going into the acute care setting. They're seeing all
Mhm.
these patient populations. They're noticing that they're not getting consulted on the maternity unit, especially for moms after an unplanned C-section or the foot drop or the pubic
Yeah.
symphysis dysfunction, everything that
Yeah.
you took the time to explain today. And
Mhm.
now they're looking for evidence-based practice to support what they want to do so that they can develop advocates on the maternity ward, nurses, physicians, midwives, to start referring to physical therapy or occupational therapy. They just don't know how to get started. What would you say to those therapists?
For those new therapists, do what I did 30 something years ago. You're going to rotate through every hospital system within the big system. So you do ortho, you do trauma, you do general medicine, you do geriatrics, you do peds, the NICU. Then you go to the maternity ward and you start collecting the data and you do an in service and you share your in service with all the OBGYNs and the PAs and the nurses that are there. I just took one in service for transfers and I made it different for the hip replacement, knee replacement, stroke, and newborn mom with a stroke because she wants to nurture and hold her baby. So we take the same thing and we flip it 5 different ways. And then you're seen as the expert, the overall go-to person. And one class that's needed the most amongst my seniors and folks here in Charleston that I can't get anyone to buy or to sponsor is the hip and knee class, and we call it jute joint love. But I'm the girl who had a hip replacement from sickle cell, a knee reconstructed because they said I was too young to get a knee replacement. But after my surgeries, I could not go someplace and get exercises for a joint after being discharged from rehab. I mean, I knew everything from rehab, but I still needed to get stronger. And there wasn't anybody available. And so own your craft, collect the data, do it, and own it, become good at it. And remember, the body is just not one thing, it's a system. So understand how the integumentary system works with the musculoskeletal system and how it interacts with the endocrine system. Just you have to put all of it together. You have to put it all together.
Phenomenal. Dr.
Thank
Brown,
you.
I cannot thank you enough. I was just joined by Dr. Jennifaye Brown, 35 years of clinical experience and just focused across all settings, the continuum of care, but really just shines as a neuro rehabilitation specialist. I cannot thank you so much for just giving your time, giving your availability, just to introduce your book. Um,
You.
Brace yourself, everything you need to know about AFOs after stroke. I think that this has wide implications for the maternal health population and just rehab therapists that are really directing and expanding their skills and their practice for this patient population that is so underserved. Dr. Brown, thank you so much for your time. Can people connect with you? Can they consult with
Yes.
you even? How can people reach you?
So I have a website, jvbneuropt.com. And from that website, you can also get the book. I also have a YouTube channel that we're just getting started, Dr. Jennifaye V. Brown. And I am being selective about what I post on there. And so it's slow but surely moving. If you go to my website, my email is up there. Feel free to contact me. I do respond to emails.
Fantastic. Thank you so much for your time. And I will make sure that people really get the links in this description, just, so that they can also consult with you if you have time available and you have services available for that. This has been fantastic.
Thank you so much. Thank you. It was my pleasure to be here to serve and to share the information that I know. And I truly am an advocate for. Thank you, Dr. Seagraves. I wish you continued success on this platform. It is very much needed.
Thank you.